A 39-year-old female presented with transient visual loss and an episode of ataxia. I'm showing you axial FLAIR and sagittal T2-weighted brain MRI scans. Describe the findings.
Let's see. Yes. The axial FLAIR and sagittal T2-weighted MRI scans demonstrate multiple focal, ovoid, high signal intensity abnormalities within the periventricular white matter. On the sagittal view, these plaques are classically orientated perpendicular to the long axis of the lateral ventricles, representing Dawson's fingers. Further high-signal lesions are noted involving the corpus callosum, particularly along its inferior margin. There is no surrounding vasogenic oedema, mass effect, or evidence of ventriculomegaly on these images.
I am showing you an axial brain FLAIR image from a different patient. What does it demonstrate, and what is the differential?
The comparison axial FLAIR image demonstrates confluent periventricular high signal with multiple scattered punctate white matter foci. This pattern is characteristic of chronic age-related small vessel ischemic disease. The differential diagnosis for focal cerebral white matter hyperintensities on T2 or FLAIR includes multiple sclerosis, acute disseminated encephalomyelitis, cerebral vasculitis, chronic microvascular ischemia, migraine headaches, and neurosarcoidosis.
What is the diagnosis? Explain the pathology, clinical course, and typical patient demographics.
The diagnosis is multiple sclerosis, a chronic inflammatory demyelinating disease of the central nervous system. Pathologically, it is characterized by autoimmune-mediated perivenular lymphocytic infiltration, myelin sheath destruction, and progressive gliosis-forming plaques. The clinical course is typically relapsing-remitting, defined by neurological deficits separated in time and anatomical space. It most commonly presents in young adults between 20 and 40 years of age, with a marked female predilection. There is also a well-recognized increase in geographic prevalence at higher temperate latitudes.
How do you radiologically differentiate multiple sclerosis from small vessel ischemic disease?
Multiple sclerosis characteristically involves the corpus callosum, particularly the callososeptal interface, which is rarely affected in microvascular ischemia. Furthermore, MS plaques are oval and perpendicular to the ventricles, whereas ischemic lesions are typically round, subcortical, or deep white matter confluent zones. The presence of lesions in the brainstem, cerebellum, and spinal cord also strongly favors a demyelinating process over microvascular disease. Additionally, acute MS plaques show incomplete ring enhancement and restricted diffusion, whereas chronic plaques do not enhance.
What laboratory tests are used to support the diagnosis, and how would you manage this patient as a radiologist?
Laboratory workup includes a lumbar puncture for CSF analysis, looking for the presence of oligoclonal bands and elevated IgG index. As a radiologist, I would recommend a complete spinal cord MRI, particularly targeting the cervical spine, to look for coexisting spinal demyelinating plaques. I would also recommend careful correlation of the imaging findings with McDonald diagnostic criteria, electrophysiological visual evoked potentials, and laboratory markers. Finally, I would recommend referral to a neurologist for disease-modifying therapies to reduce relapses and slow disability progression.